Thanks. You've just heard a series of talks that were, at times passionate, emotional, and now we're going to do something really different. And we're going to do it with somebody with far fewer social skills than the previous presenters. What I'm going to do is I'm going to touch first on some basic facts, then I'm going to take you through sort of some economic issues. And really, this market and this set of policy problems are very much like economics. They have a demand side and a supply side, and I'm really going to sort of walk you through that. I'm going to review some policy tools and then make some observations of how everything fits together. So there's three fundamental problems that have been alluded to throughout the day already, which is, first of all, a relatively small portion of the people who have a problem get care for that problem. So in this case, somewhere between 11 and 26% of people with an opioid use disorder get treated for that disorder. And just to make a note here, you've heard a whole bunch of different estimates, at least while I've been here, about that number. And this points to an important problem, which is we have a data problem. Second, about a third of the people who get treated with MAT, which means that somewhere between 4 and 9% of people with an opioid use disorder get treated with what most people consider to be the gold standard of treatment. And then just to add on to that, the retention rates are about 38% over 2 years. We heard the 50% number over 1 year earlier. So the fourth dimension of the problem is that it takes a long time once you recognize the illness or have the illness to get into treatment for that illness, assuming you eventually get treated. And depending on the study that you look at, it's somewhere between 4 and 7 years from the time there's an onset of diagnosable symptoms to the time that you actually get treated. And then, so that's the demand. That's a lot of it. I just told you about demand. Okay, for the non-economists in the group, I'm going to supply now. And the treatment programs don't do what we want them to do very often. 41% of treatment programs offered MAT, and that means just lots and lots of them either offered only a narrow version of MAT or none at all. 23% of publicly funded facilities offer MAT, okay? That is a historical legacy that is really a residue from the 1970s. And then if you do offer MAT, most people take it. And so that's an important clue to where we might be going policy-wise. 14 states lack a facility that offers MAT and Medicaid coverage for MAT. Okay? That's demand and supply. Okay, so the policy tools are really, again, can be viewed as demand and supply. Affordability and access is kind of demand. And there we have Medicaid expansion and Medicaid design as one tool, insurance regulations and subsidies as another, including parity. Now, one of the things that I think has been a under-attended to area is regulation and contracting of supply. States regulate providers, specialty providers, through licensure, through contracting, and through standards. And I'm going to sort of come back around to that in a few minutes. And then workforce regulation. And then I'm only briefly going to talk about targeted grants. And they have to be mentioned because we've been pouring a lot of money into them. Or at least it seems like we've been pouring a lot of money into them. But I think what we're seeing is their impact has been somewhat less than we had expected. And I guess Alan's probably going to talk about that a bit. So let me start with the affordability tool in Medicaid. And before I launch into this, I just want to remind you that even though throughout the day, and in the last session brought it up too, we've sort of been talking as if this happens to everybody in the United States. That's not really quite right, at least data-wise. Over half of the people who have an opioid use disorder, or actually misuse even, have incomes below 250% of poverty. It's still largely a low-income disease. And I think that is why you're going to hear a lot about Medicaid, because, in fact, that's our low-income insurance program. We have wide disparities in how states decide to cover opioid treatments. 4 out of the 45 states surveyed recently excluded buprenorphine and methadone from reimbursement in their Medicaid program. There are huge coverage differences. There are annual limits on the number of prescriptions you can get. There are limits to which providers can see you and can prescribe, and they definitely constrict the availability and the demand for care, demand and supply of care. Now, the supply of substance abuse treatment depends in good measure on the financing systems that are out there. Specialty substance abuse treatment systems are highly constrained by the insurance arrangements in their environment, and this is, again, a legacy from the 1980s. Until the Affordable Care Act, 50% of our spending on addiction treatment was paid for through the block grants. Okay? It's only recently that we've seen this huge injection of insurance-based money into the system. My recent estimates are it's about $5 to $6 billion of new money each year since the Affordable Care Act passed. That is a big jump in what happened. So the recent coverage expansions have been very important for that reason. But what's interesting and what's important to note is that specialty providers is not where that new treatment is coming from. It's mostly coming from office-based clinicians because, in fact, we're carrying on the legacy of a treatment system where we've underinvested for 50 years. And it's going to take time to catch up. And much of the new investment right now is coming from private venture capital. And again, that's not going to be primarily oriented towards Medicaid. Just to give you an idea of the impact that can be had, if you look at this graph, this is a comparison of the expansion states with the non-expansion states. And so that first bump up you see is in 2010. So that's before the expansions actually happened. But states that realized they had an opioid use problem strategically decided that they were going to expand coverage. Governor Kasich has been very vocal about this. That next period there, where it was flat, is that period before the expansion happened, and that second bump is really the impact of the expansion itself. Now, Parity increases spending, financial protection, and treatment, especially when it's linked to coverage expansions. Oregon saw a increase in spending for alcohol, but not drug treatment. Parity in the marketplaces increased coverage, and as I said, injected close to $5 billion a year in new treatment dollars. Children's mental health treatment increased, but including substance use disorders, but the associated costs did not rise because, in fact, the rationing was done in a very sort of scalpel kind of way, where less sick kids got less care, more sick kids got more care, and on average, it didn't go up a lot per kid, even though overall more people were being treated. And then Parity increased inpatient substance use disorder treatment. Now, reimbursement is very important because it in fact makes it possible for the providers to do their work. And low fees means low participation rates. Psychiatrists have the lowest participation rates in Medicaid of any medical specialty. Majority of states that cover OTPs have no Medicaid reimbursement for buprenorphine or naltrexone. And so what you see is the ability of the specialty sector to meet that demand, even though they haven't yet, is highly constrained by the way we pay them. What we've learned is that offering of MAT is associated with some very clear characteristics, and this is important as we think about policy. Being certified by a mainstream healthcare organization like JCAHO or something is a strong predictor of offering MAT. So to getting into the mainstream, accepting insurance. A third of publicly funded specialty treatment providers have never billed insurance. Okay? They are outside of the mainstream of American medicine. If you're located in a state where states have medication-assisted treatment agents on their preferred drug lists, you're more likely to see facilities offer care, and that is extraordinarily important. I'm just going to sort of skip through this quickly because I'm going to be documenting the obvious otherwise, which is that when you waive more doctors, you get more care. And if you don't have any doctors with waivers, you're going to get a lot less care. And so there it is. Now, the policies that now we talked a lot about training, and and I think training is important. And I was one of the people who browbeat Yale University to try to get them to do the mandatory training. But it may not be enough. And we're seeing, and there's evidence emerging that intervention either before training or after training will get more people and more providers on board. Payment models that move money and people towards non-physician providers has the potential to do a lot, and I'll provide you with a little bit of information on that in a minute. And then paying and encouraging innovations like telemedicine, telehealth in rural areas is important. Now, one thing that's come up a lot is bundled payments. ASAM has a proposal. Addiction psychiatrists have a proposal. There are a lot of proposals out there. Let me take us back to the very beginning of what I started talking about, saying that there are those three fundamental problems. We don't treat very many people. We don't necessarily treat them with the things that are going to get them better, and then we don't retain them in care. If you're going to do a bundled payment system, you have to attend to all three of those pieces. Right now, there is no proposal that attends to the first one, which is the outreach and engagement. You need to pay people to get people in. You have to pay the healthcare system not to be passive and wait for patients to show up. And I think that if you don't do that, you're never going to make huge progress on that one in four getting treatment. And that's on a good day in the United States. Okay? And so I think the principles behind bundled payment systems is that you want to pay for all three pieces, including retention and recovery, remission, and you want to do so in a fashion that encourages that it be done efficiently. Mid-level prescribing. The CARA legislation opened up the doors from the federal side to do that, but they made it conditional on state decisions about scope of practice. We've got some new data that is just coming out showing that there is a dramatically higher rate of waiver applications and waivering for nurse practitioners and physician assistants in states that have wide scope of practice laws compared to the ones that have narrow. They don't even bother to try in the narrow scope of practice areas. So in fact, the evidence that we have so far, and we don't know yet whether that leads to more delivery, but it looks like we're on a path where it will, and that's an important lesson learned. Retention rates. I think there are a variety of policies that can be undertaken there. Everything from things in the legal system to psychosocial interventions to the use of telemedicine, et cetera. And again, I think we need to have payment systems that are aligned with keeping people in treatment. So limits on the number of prescriptions per year, limits on the number of visits, aggressive managed care, prior authorization. Again, those on one hand violate parity. On the other hand, they're just bad policy for here. Okay, let me finish up by sort of giving you my high payoff activities. One, Medicaid expansion matters a lot, and while we've gone down the road, there are still a bunch of states who are considering it, and hopefully more will in the future. It has made a huge difference. Medicaid design is also important. Again, because of the population that is most at risk here, focusing on how we pay and whether we pay generously enough to induce the talent that we need to get into the game is very important. State regulations and contracting for facilities is very important. I mentioned a few characteristics. We have not revisited licensing laws for facilities in this country since about 1970, okay? We know what medicine looks like, what environments that yield evidence-based treatment look like. We should make sure that our licensing and certification requirements line up with those clearly. And states have the opportunity to do it. They have a lot of clout in this area. Again, state regulation of NP and PA scope of practice. And I just want to finish by saying that we've put a lot of money into targeted grants. And I worry about two things. One is when you look around, it's not a lot of money per state. It winds up being around 10%. Is that about right? And it'll be a little bigger next time. But the second thing is that we have a long history of when you have appropriations-based grants that people don't invest as deeply in the infrastructure that you need. And when the grant goes away, the services go away. And therefore, if you're thinking about this, I think figuring out how to push the money into mainstream programs that are here to stay, that serve the targeted populations in well-known facilities might be a wiser way to use the money.